Hello, everybody, and welcome to this interesting webinar about the many phases of ultrasound and how we can use these techniques for the evaluation of the pancreas. I have the task to show you what transabdominal ultrasound can offer us together with the many techniques that are available when we talk about pancreatic pathology. So, as you probably already know, ultrasound is usually the first line imaging technique that it's used in the evaluation of a patient with abdominal symptoms. It's a very easy to use technique, cheap, no irradiation. You can repeat it as many times as you like. It is also very accessible, and it's also a real-time imaging technique. The problem is that even if it has so many advantages, it lacks in specificity. So even if you are able to see some pathologies, there are situations when you cannot say exactly what you are looking at, only that there is something pathological with the patient. The new technological developments, on the other hand, brought new ultrasound-based features that are available, and together with conventional ultrasound can offer you another image and another approach of the lesions that you are going to evaluate. The new features that are implemented combined with the established ultrasound features created this new concept of multiparametric ultrasound that include B-mode ultrasound, color and spectral Doppler ultrasound, contrast enhanced ultrasound, and probably the last that appeared on the market, the ultrasound-based elastography techniques. Let's see how we can use this when we talk about pancreas. I don't think I'm going to tell you too many new things, but just remember that when we use ultrasound for the evaluation of the pancreas, we use the landmarks, the vessel landmarks, the splenic vein, and we place and we find the pancreas in front of the splenic vein using the acoustic window that is created by the liver. And we have the inferior vena cava that shows us where the head of the pancreas is, the neck of the pancreas in front of the conference between the splenic vein and the mesenteric vein. In front of the aorta with the superior mesenteric artery, we have the body of the pancreas, and we use the splenic vein to find the tail of the pancreas. Of course, the organ is a little bit more difficult to see as compared to the liver because it's retroperitoneal organ, so it's far away. You need a little bit of skill to find the structure, but by using progressive compression, usually you are not going to have any problem in evaluating the whole organ. It is very important whenever we talk about ultrasound to evaluate complete the organ in order to avoid to miss the pathology that is in areas that you have not seen when you have made the complete evaluation of the structure. So just a little bit to remember the anatomical features of the gland. Let's talk about pathology, and I want to remember you that I'm going to talk only about transabdominal ultrasound, but during this webinar we are going to hear also information about the other techniques that are available for the evaluation of this organ. What about pathology? So first, acute pancreatitis, inflammatory pathology. Ultrasound is here again one of the diagnostic procedures that should be performed first in all patients that are suspected of having acute pancreatitis. It is the best method to evaluate at baseline the possibility of the etiology, a biliary etiology of the acute pancreatitis. So you can determine, it's the best method to use to determine if the patient has gallbladder stones or not, or if you have a suspicion that can be a stone in the main biliary duct. But it can give you also information regarding the positive diagnosis of acute pancreatitis. At onset, so you can find positive elements of diagnosis of acute pancreatitis, like an enlarged gland with a hyperechoic bursa aumentalis. Remember the landmark that we are using to evaluate the structure. It gives you also the possibility to have differential diagnosis for the symptoms of the patient, gives you information about the etiology, especially the biliary etiology, and the suspicion of stones in the main biliary duct, and can give you also information about the severity. We can use this technique also in the follow-up of this patient, like it's a dynamic real-time examination that can be repeated at any moment. And you can find in the course of evolution of this patient the developing of complication. It's also helpful to monitor the patient that have developed fluid collections. And you can also guide the diagnostic and therapeutic intervention later in these patients. So these are the advantages, but of course you have also disadvantages and limits. One of the most important limits is usually the impaired acoustic window. So you have to have an acoustic window in order to be able to see the gland, especially when you have an ileus in acute pancreatitis. Something usually this is not possible because of the overlaying bowel gas, or if the patient is obese. So the rate of visualization of the pancreas in acute pancreatitis, it's ranging between 62% and 90%. It's still an operator dependent method, so you have to learn it, and you have to have a little bit of skill to see the pancreas and also to examine a patient with acute pancreatitis. And the main problem of the conventional ultrasound is that it's not able to detect the pancreatic necrosis, because you cannot assess actually by conventional ultrasound the organ perfusion. This last limitation of the technique was changed by the appearance of contrast-intense ultrasound that allowed the assessment of the organ vascularity and the assessment of the necrosis. It's a safe method with fewer complications and can be used also in patients that have impaired renal function, which is usually the case in severe forms of acute pancreatitis. And it can be used to diagnose and follow up of acute necrotitis in pancreatitis, because you can evaluate which are the areas where you are going to have necrosis, because of the inflammatory process. And this is stated in the new guidelines regarding the non-hepatic application of contrast-enhanced ultrasound that are available since 2018. So when you use conventional ultrasound, you can have elements of acute pancreatitis, like an enlarged gland due to the edema or the presence of the hyperechoic bursa aumentalis, but you cannot say anything about the vascularization and the vitality of the organ. While if you use contrast study, you can see very nicely that this pancreas, it's actually almost completely necrotic. There is no enhancement in this area after you use the contrast study, and this gives you the severity of the lesions that are going to be in this patient after the disease is reversed. What about elastography? The other feature that is now available to use together with conventional ultrasound and contrast-enhanced ultrasound, it's available in most of the machines that are available from different manufacturers. The technique requires a clear visualization of the gland, can be performed both by using strain elastography, qualitative or semi-quantitative, but also by using shear wave elastography. Studies that were performed in normal volunteers showed that the wave velocity in a healthy pancreas is approximately 1.4 meters per second. And there are studies that were used, looked for the utility of this technique in acute pancreatitis, but unfortunately the results are conflicting. But actually, when you perform it, higher pancreatic shear wave velocities are found in patients with acute pancreatitis as compared to a normal pancreas. due to the conflicting results, is not used in clinical practice together with contrast enhanced ultrasound and conventional ultrasound for the evaluation of these patients still. What about chronic pancreatitis? Again, after anamnesis and clinical examination, usually ultrasound is the first preference as an investigation for these patients. It has a good specificity here, but it lacks sensitivity because you can, when you see elements of chronic pancreatitis like calcification or dilatation of the EFSUMB duct and irregularity of the EFSUMB duct, you do not have an early diagnosis of chronic pancreatitis. The disease is already established, so it's not an early stage. And actually, ultrasound is not able to find these patients in early stages. This is why it lacks sensitivity, but it's quite specific and you find the lesions. The same results were proved also by a systematic review and meta-analysis. And you have here an image of a patient with chronic pancreatitis with calcification in the head of the pancreas and a dilated EFSUMB duct, irregular, also with calcification. When you have these elements, they are quite specific, 98% specificity for ultrasound, but again, lacks sensitivity. What about elastography? If we use elastography in these patients, either strain elastography or strain ratio, strain histogram, or shear wave velocities, they are significantly higher than the healthy volunteers because the organ is stiff when we are talking about chronic pancreatitis, and they are also significantly correlated with stages of chronic pancreatitis. More you are going to hear when we are going to talk about EUS based techniques. And actually also transabdominal elastography may be used in addition to imaging tools for the diagnosis and grading of chronic pancreatitis. But again, more information when we talk about EUS. Let's talk about focal lesions now. Pancreatic solid neoplasms are not so rare as we would like in clinical practice, and actually ductal adenocarcinoma is the most frequent solid lesion of the pancreas, followed by neuroendocrine tumors. So whenever we find a solid mass in the pancreatic gland, it has to be considered ductal adenocarcinoma until it's proven otherwise, because this is the most frequent lesion. Usually it presents like a solid and markedly hypoechoic mass, usually not very well defined, and when you compare it with adjacent pancreatic parenchyma. On the other hand, the neuroendocrine tumors are usually also hypoechoic, but better defined, so they are well-defined homogeneous lesions. But of course, ultrasound, transabdominal ultrasound is not enough for differentiation between the two lesions. So you are going to find the mass by ultrasound, but you cannot say if it's a ductal adenocarcinoma or it's a neuroendocrine tumor. So most of the solid lesions are going to be detected by transabdominal ultrasound, but without specificity. So you cannot have a positive diagnosis only by transabdominal ultrasound. What we can do, again, we can use contrast enhanced ultrasound because this technique is going to bring us the information about vascularization of the structure. So you have here the hypoechoic tumor in the head of the pancreas. So you detect the solid lesion by ultrasound, and you can characterize the vascularity by using contrast enhanced study. And you can use CUS to characterize ductal adenocarcinoma because usually this lesion is a hypoperfused tumor. So you are going to see that the area it lacks enhancement during the arterial phase as compared to the other parts of the pancreas. So it's a hypoenhancing, hypovascularized tumor, and you can use this technique to see this and to prove this, as compared to neuroendocrine tumors, which are usually hyper-enhancing in the arterial phase. Again, well-defined hypoechoic lesion in the head of the pancreas. And when we do the contrast study, we are going to see the enhancement of the lesion in the arterial phase, a hyper-enhancement, as compared to a ductal adenocarcinoma, which is hypoenhancing in the arterial phase. So this can be used in most of the cases for the characterization of the tumor. What about elastography? In pancreatic ductal adenocarcinoma, shear wave velocities are usually significantly higher than in normal pancreatic parenchyma, as well as in the parenchyma of the pancreas that is surrounding the tumor. The problem is that also neuroendocrine tumors tend to be harder as compared to the adjacent pancreatic parenchyma. And usually you can have overlap in the velocities, unfortunately, between malignant solid lesion, benign one, and also chronic pancreatitis. This, when we talk about transabdominal ultrasound, more evidence are related to endoscopic ultrasound, and this is something that you are going to hear in the next presentation. Another possibility is that in clinical practice, you are going to find a cystic lesion in the pancreas. There are a great variety of lesions, cystic pancreatic lesions, starting with cystic pancreatic neoplasm, like serous adenoma, mucinous adenoma, or intraductal papillary mucinous neoplasm. These are the most frequent cystic neoplastic lesions of the pancreas. On the other hand, you can have also pseudocysts, which are lesions that appear after acute pancreatitis. They are pseudocysts. They are usually sharply delineated anechoic lesions, but sometimes they have distal acoustic enhancement, and they can have also walls inside and areas that are echoic inside the structure. And it's usually pretty difficult when you do not know anything about this patient to say only by transabdominal ultrasound, conventional ultrasound, if you are facing a tumor, a cystic tumor versus a pseudocyst. This is also the most important question, because while pseudocysts are completely benign, some of the cystic lesions can be malignant, or they can have potential of malignancy. So the management is going to be completely different depending on the positive diagnosis. What can we do? So again, ultrasound is very good for detecting the lesion, but it's not enough. But we can use contrast-enhanced ultrasound again. And for pseudocysts, the lesion is going to be completely unenhancing in all the phases of the contrast study, because there is only necrotic tissue inside. So even if you have echoic structures inside the transonic structure, the liquid of the pseudocyst is going to be completely unenhancing in the arterial phase, and you can do very easily the differential diagnosis between the cystic neoplasm and the pseudocyst. Why? Because if you are facing a cystic neoplasm, all these areas inside the lesion are going to enhance in the arterial phase, because there are structures inside of the cystic tumor, actually. So as you can see here in the contrast study of this cystic tumor, we see very nicely the enhancement of all the lines that are inside the tumor. So again, contrast-enhanced ultrasound gives you more information in these patients. What about elastography? It can have also a role in pancreatic cystic lesions, both strain elastography and shear wave elastography, in particular those that are based on RF technique. Usually the shear wave velocity in a serous adenoma, for example, is infinitely high, and you cannot get numerical values. So you are going to have not a measurement when you are performing the elastography. While if you have more complex fluid content, like in a mucinous cystic lesion, for example, again, the shear wave velocities are very high, but you get numerical values so you get a result when you are performing the elastography. But again, this technique, it's at the beginning in using for the characterization of these lesions, and it can have can give you some additional information. But again, we need more studies when we are talking about elastography in such a lesion. I hope I was able to convince you that conventional ultrasound, together with the other features that are available in the multiparametric ultrasound, like ultrasound-based elastography or contrast-enhanced ultrasound, can give you more information that can lead you to a correct diagnosis. For those of you that are more interested in this, do not forget that next year I wanted to invite to Timișoara for the World Congress of Ultrasound that is going to be in May 2022. Thank you very much.
Alina, thank you very much for this comprehensive review of all the multiparametric ultrasound techniques we have to characterize the different pathologies in pancreas. I have seen one question from the audience to you. In resource-limited areas, was asked by Henry Zong, what methods or techniques you can use to see the pancreas with ultrasound? I think this is a question with regard to basic techniques to visualize the pancreas with ultrasound. Can you answer, please?
Yes, thank you very much for the question. So ultrasound, you have to learn how to evaluate a patient with ultrasound, and especially for the pancreas, the learning curve is a little bit longer. But if you have, if you are patient and you use the acoustic window of the liver, you start in the upper part of the abdomen, preferably in a patient that is on fasting. And you start by making a compression, progressive compression. Usually you are going to be able to avoid the gas from the stomach, and you are going to be able to see the pancreas by using the landmarks, the splenic vein, the confluence with the mesenteric vein, and also the aorta and the inferior vena cava. If the patient doesn't have an acoustic window for the pancreas, you can create one by giving your patient still water. So they have to drink around 500 milliliters of still water, and you have to wait around a few minutes for the gas to go out from the water, and you are going to create actually the transonic medium in front of the pancreas, and by this you are going to create an acoustic window and you are going to be able to see the pancreas. So these are a few tricks that you can use in practice to improve the image, but mainly if you practice and you see a lot, you do ultrasound on a regular basis, and you see a lot of patients in time, you develop actually the examination skill, which is not very difficult. You just need to use it as a routine during your daily activity.
Thank you, Alina. Are there further questions from the audience or from the other lecturers? Alina, one short question from me. Are there any studies comparing the established technique of contrast-enhanced computed tomography for evaluation of pancreatic necrosis to the contrast-enhanced ultrasound technique? Do we see the same with both techniques?
Yes, there were some studies in the past by Rix, I think, was the author, that looked head-to-head in contrast studies with contrast-enhanced ultrasound and CT, and there were no differences in evaluating the degree of necrosis by using contrast-enhanced ultrasound as compared to CT. Of course, you have to see the pancreas. This is the first line. If you do not see by conventional ultrasound the pancreas, you are not going to be able to do a contrast study, and this can be a limitation, especially in severe forms of acute pancreatitis, because if you do not have an acoustic window and it's not possible to visualize well the gland, you are not going to be able to perform a contrast study. But if you see the pancreas, then the CUS is very good for the evaluation of the necrosis. And it's also very easy to use because you don't have the drawback of the renal failure, and it's 5 minutes. Actually, the examination takes another 5 minutes after the conventional ultrasound to do it during the same session.
Thank you.